Hi, my name is Marissa Jacob. I'm a PA student at Westfield State University, and I'm working with my preceptor, Dr. Stephen Smith. Today we have Colin. He's a 15-year-old male presenting with his mother with a chief complaint of lower abdominal pain. He describes the pain as periumbilical that started around 10 hours ago that migrated to the right lower quadrant within the last few hours. He has vomited 2 times with associated nausea. It's important to note here that he is also a full code. His past medical history is pertinent for childhood obesity, but he doesn't take any medications or have any allergies. On review of systems, the patient explains the lack of a bowel movement over the past 24 hours, as well as chills. On physical exam, he's febrile at 101.4 degrees Fahrenheit, as well as slightly tachycardic at 104 beats per minute. He also presents with an elevated BMI. He is in moderate distress and has a positive Rovsing and SOAS signs on physical exam with guarding, rebound tenderness, and normoactive bowel sounds. Because of this, I have a high suspicion of appendicitis with or without rupture. A CBC, CMP, urinalysis, ultrasound of abdomen and pelvis, and CT of abdomen and pelvis were ordered. The CBC showed leukocytosis with left shift. The CMP and the UA were unremarkable. The ultrasound of the abdomen and pelvis showed a non-compressible tubular structure in the right lower quadrant, but was difficult to assess due to the patient's body habitus. The CT abdomen and pelvis showed periappendiceal, fat stranding, and obstruction at the base of the appendix, lightly represented in appendicolith. It also shows the appendix length of 12 centimeters, diameter of 10 millimeters, and a wall diameter of 5 millimeters with no evidence of rupture. The official diagnosis is acute appendicitis without rupture. Immediately, we want to start the patient MPO with 2 large bore IVs for IV fluids as well as ceftriaxone and metronidazole prophylaxis, as well as IV morphine for his pain control. He will be admitted to surgical service for a laparoscopic appendectomy. Upon this decision, I explain the diagnosis of appendicitis and that this is an inflammation of the appendix, likely caused by a fecalith or a piece of stool. I also explain that surgery is needed to remove the appendix and it is done through some small incisions. There are some risks to the surgery, including bleeding, infection, and injury to the nearby bowel. However, this is a common procedure, with Colin only having to stay in the hospital 1 to 2 days post-surgery. He will be started on a clear liquid diet and slowly transition to a regular diet during that time. He can start normal activity within a week of discharge. However, he needs to avoid strenuous activity and heavy lifting for 4 to 6 weeks post-procedure. Colin and his mother gave consent to the plan and agreed to make a follow-up visit post-surgery with his PCP, as well as return to the emergency room for any abnormal discharge of the incision sites, any sudden severe abdominal pain, any nausea or vomiting, or any signs of fever.